cystic meningioma. So different types of meningioma I came to learn from Professor P.M. Tandon. Dr. Samir Nandan, welcome you, and Dr. Dheerendra Prasad. Sir, thank you for coming.
मैं ऐसा करके इसको प्रेजेंटेशन पे लगा के और बी दबा के ब्लैंक कर देता हूँ, ठीक है?
Sit. Sit.
So, good morning everyone, and welcome to AIIMS New Delhi. On behalf of the Institute, it is my privilege to welcome you all for the 35th edition of Sarveshwari Memorial Oration. Just to put the facts right, it is one of the long-standing orations established by this Institute, and eminent neurosurgeons of international repute delivered this oration. Just to begin with the proceeding, I now request Professor M. Srinivas, the Director of AIIMS, to welcome the orator with a bouquet. So to carry forward with the proceedings, I now request Professor S.S. Kale, the Head of the Department of Neurosurgery, to introduce the oration.
Professor Srinivas, Director of All India Institute of Medical Sciences, Professor Tandon, Professor Saini, Professor Bittal, Chief Neurosciences Center, Professor Gaikwad, all the other distinguished faculty from CN Center and All India Institute of Medical Sciences, delegates, guests, ladies and gentlemen. I welcome you all to the 35th Sarveshwari Oration. It has become kind of a flagship of the Department of Neurosurgery, and over the years, many distinguished orators, starting from Dr. Chris Christiansen, who probably was the first to deliver this oration at least 35 years ago. And what a fantastic coincidence that on this Diamond Jubilee year of the Department of Neurosurgery, we have one of our own alumni, one of our own alumnus, Dr. Dheerendra Prasad, deliver this oration in its 34th edition. Fantastic. So let me begin. Can I have the presentation just to revise again about the person in whose memory this oration has been fixed? Can I have the slides, please? Okay. Late G. Sarveshwari was born on 10th June 1947. She was the eldest child to Mrs. and Mr. G.S.K. Rao, who was an electrical engineer from Bangalore. She had her early schooling in the Andhra School near ITO in Delhi, affiliated to the CBSE. Thereafter, she did her BSc with honors in 1968 from the prestigious Miranda House College for Girls in the Delhi University. She was an excellent student and stood first in the Delhi University in her Masters in Botany and was awarded the Panchalan Maheshwari Memorial Prize for her achievement, the student standing first. Soon after her MSc, she got married and settled down to a happy family life. Between 1968 and 1975, she became the proud mother of 3 children. The first symptom of brain disorder was noticed in May 1974 in the form of severe headache and loss of consciousness. The project doctors of Balco, that is the, I think, Bharat Aluminium Company, which is in Korba in Rajasthan, not very far from Delhi, where her husband was employed, referred her case to All India Institute of Medical Sciences, New Delhi. At AIIMS, she was diagnosed to have a malignant astrocytoma. She was operated upon on 12th of March 1976 and a radical tumor excision was done. This was followed by radiotherapy. She made a quick and complete recovery, but the tumor recurred and she succumbed to her illness on 3rd of February 1977. This oration was instituted through a munificent grant by her loving husband. The first oration was delivered in 1981 by Professor Christian Christiansen of Oslo, Norway. Over the years, some of the other distinguished orators have been Dr. Rasmussen, Dr. Mathai from India, Professor Bricolo, Alan Crockard, Tetsuo Kano, Professor Colwell from Salt Lake City, USA, Andrew Kai, Menezes, Dr. Kawase, Fred Gentili, and we had a series of Japanese surgeons in the last 2 years. I think it was Professor Goto and Professor Kawasaki, I think, Tanikawa, who delivered it last year. And this year we have a distinguished alumnus, Dr. Dheerendra Prasad, who is a world-renowned expert on stereotactic radiosurgery, to deliver the 35th Sarveshwari Oration in All India Institute of Medical Sciences. Thank you very much for your attention.
And now I request Professor Ashish Surya of Department of Neurosurgery to introduce the orator formally.
Good morning, all my teachers, too many teachers, seniors, colleagues and friends. Can I have a slide? Yeah, thank you. It's a proud privilege to introduce our alumnus. We call him DP actually, and that is his nickname that has been there since I joined 32 years ago. And the moment I was there in '94, he was in the US. Nandita was there as the chief resident. I was the junior resident. So Dr. Dheerendra Prasad is the chief of gamma knife radiosurgery, professor of neurosurgery, radiation medicine, and radiation oncology at the Roswell Park Comprehensive Cancer Center, Buffalo. He schooled from the Springdale School, and he passed in 1981. He was, like all of us are nerds, he was a big nerd, and but always a topper, a national merit scholar, national talent search scholar, and he joined AIIMS in 1981 as the MBBS student. He did his MBBS. After that, he joined the 6-year MCH from 1986 to 1992. After that, he left for University of Virginia and where he was the last Lexell Fellow for stereotactic radiosurgery, the Faculty of Neurosurgery, and then a co-director of gamma knife radiosurgery in 2021. He's been very active over the last, I would say, 15-20 years, mentoring AIIMS. I think really mentored most of our faculty who've been doing radiosurgery here. Thank you, sir. Thank you very much. And he also mentored the gamma knife installation as well as the training the faculty at AIIMS Bangalore and recently the Fortis in Delhi. And this is gang of gamma knife experts in Stockholm, and they celebrated the 20th anniversary at Buffalo with 5,000 patient series, a very huge experience. The team as a leader, teacher, and a physician par excellence. He stayed in Buffalo for, I think, more than 2 decades, and as per him, it has only 4 seasons, 3 are winters, and he's enjoying a steam bath there. I wish I would have it in Delhi, but then I would only use for 5 days, and loves to party in all over the places. His beautiful wife, Komati, is also here with us. She's a glass artist, and blessed with 2 children. Both are Shifalika, the beautiful young lady here, sitting with us, and she is doing her med school from University of Medicine, Buffalo, and she's an aspiring neurologist. I would say you can change it to neurosurgery. And Samendra is not with us here, but he's an engineer and also now following, he's doing his law school. Both children are very bright, have done prestigious Jefferson Scholarship in the UVA. And I thank you, sir, for coming and hear the oration, living the oration of the 35th Sarveshwari oration. So thank you.
May I now invite Professor Dheerendra Prasad to deliver the oration, please.
वैसे रहने दो, बंद करके निकाल, रहने दो, बस HDMI निकाल के दे दो. Good morning, everybody. Good morning, Professor Tandon, all my teachers, Dr. Saini. Remember you gave anesthesia to the case that I operated to pass my MCH? Dr. Gaikwad, as he said, we started at the same time, each trying to please very difficult masters. Nalin Mishra for you, and Professor Tandon, and Professor Banerjee, and Professor Jobastata, Professor Mehta would make sure nothing was left standing at the end of the day. So those were fun times. We worked hard. I think we played hard, and we learned. I chose this title because, and actually it'll come right home, starting all the way back to where Professor Tandon and Professor Bhatia trained, how the neurosurgical arc has been always dominated by disruptive technology, disruptive ideas, and the idea that dogma is sold to us for many reasons. Dogma could be the result of it's safe for patients. Dogma could be the result of the fact that someone is so stubborn and in charge and in power that they don't want to let go of their own ideas. But we face it all the time, and medicine is no exception, and especially in medicine, it can be a real challenge. And there's a subtle difference between innovation and disruption. I think disruption is when innovation really warps the fabric of time and changes the course of destiny, but it doesn't happen by chance. Go back to my school. My principal, Mrs. Kumar, was my very first influence, an amazing force, always smiling, incredible eidetic memory, and taught us all to be fiercely independent and yet work as a team. Vasudhaiv Kutumbakam, the world is a small family, is the motto of Springdale School, and that was pretty much it. Now, I could have been a physician, I could have been a pediatrician, neurologist, PM&R. I ended up in surgery because of Professor Nandi. I still think he really showed me what a surgeon can be. And that's what drew me to surgery and drew me to neurosurgery. And every one of the people on the screen taught me something different. I was just telling Professor Tandon, he taught me to express myself precisely. He did not tolerate nonsense. I don't think he still does. And he was always more punctual than all of us, which was always a difficult one. Professor Banerjee taught me not just surgical skill, but how to use humor and a little self-deprecation to create a little humility, create a connection with the patient. Professor Bhatia taught me stereotaxy. What I do today is a direct extension of what I learned from him, what he learned from his mentors in Scandinavia. And Professor Mehta taught me, no matter how senior I get, I'm still a resident, and I need to listen to him. But an amazing surgeon. Now, all these people, what they did for me was not only did they train, but they also make sure you thrive. And so Dr. Tandon handed me over to his compadre from Montreal Neurological when Wilder Penfield used to still attend morning conferences, Professor John Jane. And in his department, I went and worked with the man who taught me creativity, perseverance, and a indefatigable quest for precision. I actually take it as a great matter of pride that I have far fewer publications than many of my colleagues in my field, because he taught me not the number, what you write matters. You cannot produce more than, and Lexell said the same, you can't really produce more than 3 or 4 meaningful papers in your career. Now, there is no question that we've all written more than that, but he really taught me to look at things very, very differently. But no seed thrives without good soil. University of Virginia was a great launching pad for me, from AIIMS to UVA, and then where I really established my own brand of what I do was at Roswell Park Cancer Institute. Not a park, but named after Dr. Roswell Park. And as you will see, Adnan Siddiqui, and Adnan works right there at the Gates Vascular Institute, and he's the CEO of Jacobs Institute, which is an incubator for innovation. I don't have enough time to show you all the wonderful things that we've been doing, but the Children's Hospital and the university, all of it together, makes the dynamic place where you learn, you thrive, and you explore new ideas. But in case you're forgetting Buffalo, most people have heard of Buffalo Wings. It's actually National Geographic's 3rd best food city in the world, and that's where it all started, at the Anchor Bar. At Roswell Park, we launched the first cancer research laboratory, uncovered one of the early papers that linked smoking to cancer. Combination chemotherapy was never done before it was done at Roswell Park. First leukemic cell cultures were established there, and a combination chemotherapy H7-3 used for AML was started there. PSA, the antigen and the test for it, was discovered at Roswell Park, which changed prostate cancer management. And then the combination of 5FU with leucovorin also comes right out of that building and the Grace Tuck Center. My good friend Myron Churchman was responsible for establishing Rituxan and CHOP, for the management of patients with Hodgkin's lymphoma. And my good many urologists from India, and he routinely hosts medical students and helps them, mentor them, and launch their career, and we work together. But I think the most notable is the most important milestone. We don't work alone. I know that it's very close to Dr. Tandon's heart, No Man Alone, the book that epitomizes neurosurgical journey, and all the way down to the closed doors, open windows. I found SBNS, Society of British Neurosurgery, one of the first proceedings. The president had actually captured a poem that talks about windows into the brain. I'm sure you've read that, but when I saw that, I remembered your book title. And these are the next generation of disruptors. An interesting mix here. Residents who have worked with me have graduated in the top row, and they're all working as CNS radiation oncologists. Incidentally, all 4 of them are pure radiation oncologists. In the bottom row, Victor is a trained neurosurgeon. Venkatesh Madhugiri is a trained neurosurgeon, and they're both training as radiation oncologists. Neil switched gears, started as a neurosurgeon, and decided he wanted to train as a radiation oncologist. And my daughter does not want to be a radiation oncologist or a neurosurgeon. Where is Ashish? She rejects both my specialties, but she wants to be a neurologist, so good luck to her. I've been doing this for a very long time. A lot of training, it's worth it, right? 11 years of residency, 3 years of fellowship, 14 years of training. Now I've treated more than 16,000 cases. When Dr. Steiner passed away, he had treated about 15,000 patients all told. So I have now surpassed him, and I wish he was still around, but we're carrying on his work. So almost every indication you can think of. Yeah, and so now let's talk a little bit about one of the most disruptive things that happened in the world of neurosurgery, and came about by this man, Lars Lexell, a neurosurgeon who was not at the point when he came up with this idea, he was working in Lund and not the chair of neurosurgery. Neurosurgery at that time was dominated by Herbert Oliver Krona, a big name in Scandinavian neurosurgery. And he was always a tinkerer. Steiner and I used to describe him with the Latin eponym Homo Ludens, the playful man. He was always tinkering. So not surprising, he is credited with the very first person to apply ultrasound. He used a crowd-camera ultrasonograph, actually he used the British version, and he would do echoes of the brain in order to detect the midline, able to locate hematomas and midline shift, taking the original surgical approach to a post-trauma patient lying in the ED from a blind procedure based on pupillary signs, which we all know, the more you learn, the less you believe them, that we took it to a more scientific approach. And as I was looking at the history of early ultrasound and its application to neurosurgery, guess whose paper I find? A familiar guy sitting here in the front row. So ultrasound has permeated and taken over a lot of what we do. Very much not a precise neurosurgical arena, okay? On the right, you see the Spiegel and Weiss stereotactic frame. So Lexell was looking for precision. He had to design his own frame. He felt that the frame that he was looking at that time, which was a German frame by Spiegel and Weiss, was an excellent frame, but appropriately looked so complicated and brutal that it belonged on a chimpanzee skull, not on a human patient. And I think Dipankar will tell you he's still using an old CRW frame in a tin box, but we all know how reliable these instruments were. But he came up with the idea of a frame that's Cartesian, so that you can understand X, Y, and Z, right from right, left from left, top and bottom. You can also, without point, no matter where you move the arc, no matter, once you set the coordinates, you can move the arc from nasient to inion, the probe holder from left to right, and you always hit the same point as long as your probe length is 190 millimeters. So he essentially came up, for radiation oncologists in this hall, with the idea of an isocenter blended into a neurosurgical apparatus. It's not surprising he took the next step. He put a kilovoltage machine, an orthovoltage machine, on his frame, started doing the very first radiosurgery with that. But it was Boria Larsson, a very smart, charming, charismatic physicist at the Gustav Werner Institute in Uppsala, who contacted Lexell and said, we have a proton beam. There are characteristics of this beam that would be ideal for what you do with kilovoltage. We should try it. And there you see him and Lexell using Lexell's frame and performing proton radiosurgery early on. Now here's where we start to see the reaction. Somehow people start to feel this could be a problem. Well, first was denial, the fourth D. I said, disrupting dogma by design. The fourth D is denial. Here's a very senior, very respected Sven Hutberg, researcher in radium HEMET, who said that, yeah, sounds like a neat idea, I don't think it'll work. And it certainly won't work for malignant disease. So even before Lexell had a device, he had denials. But he realized that the proton beam was too complicated an apparatus, and whenever you collaborate and develop research, just as you heard this morning, that the fourth generation of the blue light apparatus is sitting at IIT, and a patient is sitting at AIIMS, that's our problem. When you collaborate outside a hospital, you can't charge a few scientists to develop a device that could do exactly what he was doing in Uppsala, but do it with cobalt-60 beams. They looked at other sources. They looked at Linacs. They were not reliable back then. They also looked at ultrasound before, but the energy of the ultrasound was not high enough, and it would require a trephine and direct contact with dura in order to get the dose into the brain. But he did not want a craniotomy. He wanted to create a bloodless operation. And so multiple isocentrically focused cobalt beams became the answer. And that's the beginning of the gamma knife, or as in Swedish, is the strålningskniven, or beam knife. And the very first one that was built was not actually installed at the Karolinska at all. It was put in at the Sofia HEMET, a private hospital, because even before it was brought in, the gadget of Lars had already created politics. And so there comes the other one, difficulty. There's another D for you. But he put it in there, and along with a very young Crystal Lindquist, where he is treating the patient. Back in the day, you had to apply the frame with a plaster cast, and if you notice, the original collimation seemed like this because Lexell wanted this to be a functional neurosurgery device. He wanted to cut fiber tracts in the brain. That's all he was doing, thalamotomies. And so that's the intent back then. Of course, over time, the company, Motala Werkstatt, which actually is a boat-making company, and Lexell had a little island in the Swedish archipelago, and he would motorboat up and down. And so the company he went to build his gamma knife was the one he bought expensive equipment from all the time, the motorboat company. So Motala Werkstatt built the first gamma knife, took it to the meeting in the Congress in New York, but all they got was a vendor booth. Nobody was allowed to talk about this technology. Nothing else was really happening. Everyone spoke a lot about it. Finally, forward a few years, and 1981, Society of British Neurosurgery meeting occurs at the Royal Hallamshire in Sheffield, where David Foster had already acquired a gamma knife, and there was interest in it. And so Daniel Excel, Lars's son, went to give the Cairns lecture that year. On the left is the publication of the Hugh Cairns lecture in the Journal of Neurology, Neurosurgery, Psychiatry. On the right is the proceedings of that meeting. If you search for the word Cairns, you won't find it. If you search for the word Lexell, you won't find it. If you search for the word gamma, you won't find it. Because Lindsay Simon, sitting from the president's chair, leaned in after Danny finished and said, 204 cases of AVM, come back in 2 years. They will all have recanalized. So here's your diminishment. Do everything you can. Doesn't matter. The innovation continued, and the machine continues to evolve to this day. And what you see today is the Esprit, or its predecessor Icon, which are very, very similar. And it has an exquisite planning system, patient experience, still retains the principle of multiple focused, roughly 200 beams, which are cobalt-60, which emits radiation constantly, it decays, but the machine is super shielded, so contrary to popular representation, it does not leak radiation. It is actually the safest machine. You can, even though the laws will not permit it, it's the only radiosurgery machine in the market you can treat a pregnant patient with successfully without damaging the fetus. No other machine in the market can do that. Even proton beam can't do that. And this is the kind of lesion it produces. You can also use, the planning system was well ahead of its time, all the way to its very inception, and it really allowed you to use all the possible imaging techniques available. MRI, CT, PET scan. Today we use gallium-68 scans. We use diffusion tensor imaging, and we can get tractography into it. It's an amazing system. But that doesn't mean that the skeptics are gone. And there is no bigger skeptic than a biologist, especially a radiobiologist. And Rod Withers from California, session treatments make no sense. And we have done all these equations over the years, and we know that's not going to work. 2025, we know it works. But back then, there was a lot of this that kept us. What we showed one step at a time is that radiosurgery works even if the cell is in its dormant S phase, because the dose deposited is so high, its biological effect is higher as the periphery. And you are very, very precise, which means you're edging off into very low doses, only half a high power field away from the edge of the tumor, which means you don't have to worry about fractionating to protect normal tissue. And so, and certainly tumors and targets that are close to their sensitivity as brain will do better with single session. Tumors that are very highly reproductive and behave more like aggressive tumors, high alpha beta ratios, will perhaps do better with fractionation. But this dogmatic idea that you have to follow the 4 hours of radiotherapy was ultimately, it took a long time to prove it wrong. Ultimately, nothing succeeds like success. And yes, the disruption did come. We now know that radiosensitivity is not uniform. Tumors can have different alpha beta ratios in the primary. They can have different alpha beta ratios in their metastatic sites. The brain met could be completely different from the primary, and the lung can be completely different from a secondary. Those changes happening. And the other piece of it is that we are extremely tight with dose spillage to normal, especially with the gamma knife. The dose spillage down the thyroid and further is so low that it's extremely radioproductive. And ultimately, that's the curve of publications with the gamma knife. You could see every year more and more and more papers. And we've now started to look at alternate fractionation schemes. The idea that fractionation should be uniform is perhaps wrong. because once you deliver first or second fraction, the tumor becomes a little more radioresistant. So maybe the third and fourth need to be bigger. And that's all coming up because of new research. But what will be my Swedish that I am sure he turned to Excel and said, "Men det har människan." That's my sandbox. What are you doing here? So here's the history. It's a microsurgical procedure. I want nothing to do with your technique. Fast forward 2000, I had the opportunity to write with him and Melita Steiner our first paper on schwannomas treated with gamma knife. And the rest is history. We showed it works very well, even for large tumors, and you can get excellent results, and multiple centers reproduce this. Well, one by one, radiosurgery starts to catch the attention of everybody. Now the radiation oncologist wakes up. They say, "I have a hammer. Everything's a nail. What are you doing treating these brain mets? You treat one, another one will appear. I treat the whole brain, and I control it much better." And that's exactly what they published and said. If you don't give whole brain radiotherapy, 34% of your patients will develop another brain met. If you read that paper for surgery, 1/3 of your patients thirds of your patients would not be exposed to whole brain radiation therapy. And that took a long time. This idea that that paper somehow governed our thinking, it should not. Because if this famous headbutt had occurred in 2025, I can guarantee you 2 different outlets would have carried 2 different versions of this event. That is Matatsi and Zvidane, right? There is a French version. There was no headbutt. There was a light post in the middle of the field, and he just hit it. And there was the Italian version, how whole brain and radiosurgery was. People were reflecting it in the opinion they liked. Even people like Eric Chang took a long time to show cognitively it's better to selectively treat these things. 48% cognitive decline versus 20% if you avoid the whole brain. Took a long time. We even showed pictures to show how the brain looks. That's the brain on radiation therapy. That's the brain below there on radio. So you do focal treatment. They started counting. The next dogma was, well, 4 or more. Do whole brain. 4 or less, do radiosurgery. Took a long time to publish one center after the other and show that numbers don't matter. What matters is total volume of disease, and what matters is quality of your plan. And we published that, and we showed that the better the plan, the more conformal it is, the better your result will be. MD Anderson looked at gamma knife and IMRT and protons and said gamma knife is superior. We showed that if you are treating multiple tumors, the spillage with other techniques is higher, and you can treat as many as, oh my God, you're treating 40 brain mets. That's like whole brain. One session of whole brain is 3 gray. 10 of those are given in the course of complete treatment. The purple cloud you see here is 3 gray. In the entire treatment, treating all 44 spots, we didn't even hit the whole brain with 3 gray. That's 1 fraction of whole brain. And now it's good that we fought the fight when we did, because there was only a bunch of people, all labeled as crazy and out there, who were looking at all this, because immunotherapy comes along and shows us that these patients are going to live long enough for what you've done, we're gone. Patients are now living months, years, many years, and everything you do comes to fruition in their lifetime. So then come our immunology colleagues. They changed everything with EP, Nevo, and melanoma and went on from there. And like everyone else, they said, we can do this alone. We don't need anybody else. So the idea was, well, you can do whole brain for the poor performing patients. No need for radiosurgery. We'll just do immunotherapy. It's not correct. Now, some of us were very fortunate. I don't know how many people recognize these stalwarts in this room, but some of us learned immunology from stalwarts like Dr. Talwar and worked in the clinic with people like Dr. Malviya and really saw immunology in action. So for us, if you looked at the trials that were open at that time, most of the patients would have been ineligible, but you would have blocked them from getting radiosurgery because you're screening operate on the patient, which has its own consequences. And the sad part of it is the systemic response rates were not great. There are some new agents now that show up to 50% response, but it's still not as good as 95% with radiosurgery. So you are now deliberately shortchanging your patient because you want to go it alone. And not only that, the immunoprofile, the systemic disease, may have no relevance to the brain met because the brain met has a slightly different epitopic presentation, well established, enough to make it sense. That's why only 30% of the brain mets respond to this treatment and only 30% volume reduction on average. For that, you want to block a treatment that's 95% effective and reduces the tumor volume 65+%. And so the answer perhaps is a combination. And that is true, because not only when you do radiosurgery in the brain do you help the brain, you actually induce what is called an abscopal effect, increasing antigenic presentation in the entire body, which produces systemic responses as well. And so when you combine these agents together and do radiosurgery at the same time, you start to see a positive impact. But the gamma knife, like any knife, cuts both ways, and you definitely have side effects. And we published about the side effects of radiation, and we showed that radiation does induce necrosis. But that is for the pathologist to tell us. That's not a radiological diagnosis, even on this. Well, maybe we can. Maybe we can. We have software from Brain Lab that allows us to look at contrast washout from tumors. So what we do is a treated tumor. GBM was where this was proved by the Israelis. They do another scan, and you see the contrast washing and map it. It fills and gets out of the blood vessel in about 5 minutes. It leaves the tumor in about 20 minutes, and it hangs on and permeates damaged brain. So now all of a sudden, the enhancement, which we know now by biopsies that is necrotic areas, can be picked up. But what about metastatic disease? So what we did was we validated the same rated, and we took targeted biopsies and sent them. And we showed that areas that were tagged as viable tumor were truly viable tumor. Areas that were tagged as necrotic were necrotic. So you can actually now, in 2025, you can look at an MRI and say there are areas that are necrotic. I don't know, voice in your head when you're doing something. Single time I look at an MRI, even to this date, if a resident says, I see evidence of necrosis, I stop them and say, necrosis is still a pathological diagnosis, cannot be made on just a image. You have to do special sequences, and maybe then you can tell them apart. But in case you were wondering, I'd forgotten your lessons, they're still there, and I still hear your voice in my head. So manage the necrosis itself for side effects. Like treatment people have known for a long time, but brain radiosurgeons have never really thought about is, and we did show, systemic disease shows the degree of response matters. The more effectively you treat the primary, the more you take away, that's why RECIST criteria exist. If you see persistent disease, you change your chemotherapy. If you see persistent tumor, it's not shrinking anymore, you change immunotherapy till you keep getting a response. You do the same thing in the brain, and that's the differential you see. If you retreat based on contrast clearance, areas that are persistently blue, patients not having a new tumor, the same tumor is still not completely gone. And you know when you take it out surgically, it's always a big share of necrosis and viable disease. You can actually change the progression-free and overall. Do contrast clearance. If you see residual disease, treat it. Don't worry about it because we now have the ability to hyperfractionate, which means larger tumors, bigger than 3, their volume, it feels the steep gradients and the highly selective, very targeted delivery, but you can break the dose down into a few sessions. An adjacent critical structure like the optic we saw today in the second case could be better protected. And so we've shown you can do this for metastatic, really opens up lots of ideas. In fact, we took it one step further. They're not an extremist, and delaying, if you treat them, operate them, you will delay all their systemic therapy. You can treat them in an adaptive manner. Deliver a dose, wait for 4 weeks, deliver another dose, wait for another 4 weeks, and deliver a third dose. And that's been done. Now, you do have to be prepared for shifts, so you can correct for those. But in the end, you'll find overall brain dose will go down, tumor dose will remain identical, and your results look amazing. The best, and you replan and keep treating smaller as the shrinking field technique. But now we do this for radiosurgery, and you can see the end result can be quite amazing. It's interesting, it's best suited for larger tumors. That's the key. A few other things. Well, we do find it and there is pain, and we depend on it. Amazing that from my backyard with my telescope, I can image something that is 150,000 light years away with that level of precision, and that's the best picture I can do. We do treat them for various reasons. Most of these patients are coming by patient preference, but some will come because their drugs cannot control them anymore, and you get good responses. the bottom line is that about an 85% initial response does get diluted over time. Let's do an MVD, the Gardner hypothesis, but the reality is that you can get away with other treatments. But to excel, and to many of our focused ultrasound people will even more drive a nail through our happiness. But this is what we used to do a lot more with the Gamma knife, a very tightly focused lesion in the VIM, and you can see the improvement in the patient's handwriting. Here's the patient pre-thalamotomy. You can see a healthy looking dentatorubral tract. Here's the lesion that's been made and its evolution over time. And there's the DRT after the treatment. You can hardly see any fibers, and that coincides with an improvement in tremor. You can see the patient is showing you with a pen that I can now feed myself. So there's also a response relationship to how long it takes you to deliver the treatment, and there's the effect of the BED. You need to hit this treatment in a certain amount of time, otherwise repair begins and your effect goes down. So new sources or adjusting the doses, that's a big conversation. Things that we studied and published. Let's circle back to GBM, because after all, this is the Sarveshwari Oration, and I'll end with more or less that idea. And I can see a lot of people saying, don't tell me you want to treat GBMs with radiosurgery. And I can see Dr. Kale is starting to smile about a protocol that is open in his institute that wants to treat. Now, I know there's a long waiting list for radiation. That's not what we do. We don't, and I'll show you how much our waiting time is, because we're fortunate. But what we did show is if it fails, you can treat it effectively. So not every GBM that recurs needs to go back under the knife for surgery. We do take some of them back, especially if it's a long-term recurrence, so that we can look at markers, grade migration, and so forth. We need fresh tissue. But in general, you do repeat radiosurgery, and you use Avastin to control any effects, and you get a nice result with that. The other piece of the puzzle is, and I know this was something, again, that we were taught in training, amongst a few things that I can remember. No steroids for spinal cord trauma, correct? And resection, intratumoral decompression of a GBM will never hurt the patient. Do it aggressively, because you know the next step is not so easy and sometimes not so fast. So the phrase used today very routinely in glioma management, and many tumors actually, is maximal safe resection. What is maximal safe resection? So what we noticed was patients go into surgery, some have perhaps not a complete resection, but are out of the hospital quickly. Others are stuck in rehabilitation for weeks and don't get to us for radiation therapy, for chemotherapy. Is there a difference in those two patients' outcome? Because their KPS was roughly the same going in, but their KPS coming out of surgery looked very different. So was that a safe resection, or was that a maximal resection? So the problem is the safe gets forgotten, and what we showed was very clear. These are elderly patients. Their performance status is not the greatest going in, but when you delay the radiation therapy after surgery more than 20 days, overall and progression-free survival will both suffer. So then for the surgeon, and what's the most important significant add-on to all of this is adjuvant temozolomide. So if you do a surgery on a patient with a GBM today, the idea should always be about preserving neurological status so they can get out of the hospital and then get them to the next adjuvant treatment as quickly as possible. We also looked at performance status in the elderly versus, and we actually find that yes, while broadly KPS has an influence, like all glioblastomas, it's not so much in the elderly population. The curves start to cross with each other. So really, function preservation out of the hospital quickly is the goal. Sometimes, I know we talk about biopsies inferior to decompression, but it's all about how quickly you can get them to the next step. If radiation therapy is going to be delayed, you have no choice. And we have a vaccine now at Roswell, which I think is going to be the next landmark for our institute. My colleague, Dr. Fenstermaker, chair of neurosurgery, along with his colleague, Mike Shichelski, have worked on a surviving vaccine. It's a cancer-associated protein that's widely expressed in many, many tumors. And we have a vaccine now that has gone, it's called Sarvax-M. It is shown in preclinical studies in melanoma and glioma to be effective. And then it's now been tried in a phase, now we're in the phase 2A, 2B stage, and is outperforming comparable groups from the Stupp protocol. And so we are hopeful that this is going to add another layer to the management of all these patients. And the last couple of points, one is the dogma of eloquent brain. I think all brain is eloquent, but that's a very broad statement. But people get very concerned about doing radiosurgery around the motor strip because they feel, or the brainstem, where we've shown, here's work that my daughter did with Doug Konziolka showing that when you treat brain mets in the motor strip, motor cortex, you're still going to be able to treat them successfully, control them adequately, and it's best done when the patient has not yet manifested neurological deficit. Once they become deficient, their outcomes start to drop. Brainstem mets, same thing. We've published data to show that the mean survival of these patients is much better than people used to think, and that this is not a reason to back off and start doing fractionated radiation or whole brain. Brainstem is certainly a safe target, and now with hypofractionation, it's a very safe target for radiosurgery. You can also treat meningiomas overlying the motor cortex very safely, and you will see their neurological deficits improve over time. And certainly, there is a response to dose and volume reduction in there, although the range is much, much less steep. And you get excellent results. Hypofractionation is certainly an option, but you have to get your dose above 25 gray, which means 27 and 3 is a better regimen than 25 and 5 when doing radiosurgery for the motor strip. Now that I've said, okay, we disrupted everything and we've created all these ideas, I need a lot of patients to treat, right? Who has time for all this? So that's the next thing. But we have a lot of tools now that can make radiosurgery much more efficient, much more effective, way beyond anything Lexell would have imagined, but just as meticulously worked up as Lexell would have liked. So the end result is you have inverse planning tools that can help you cut down planning time very, very markedly. You can plan 20 brain mets in a few minutes. But once you know that you have to plan 20 brain mets in just a few minutes, you also need to draw those 20 brain mets. So BrainLab has an excellent tool called SmartBrush, which actually lets you automatically segment all the tumors in the brain. And it's very, very effective. Here's what we did comparing it with GammaPlan, and that big pink circle right in there. 277 lesions were accurately detected by BrainLab, and as by the manual segmentation, it can draw 30 brain mets in about a minute. Label them independently, ship them to your planning system, prescribe dose, calculate, and then just sit and watch the kettle boil. And it's you're spending your best time on the best part of the procedure, which is actually treating the patient, not on everything else. There are some false positives and negatives, but it's very highly correlated. What was most interesting to me was that in 5 patients, we actually found brain mets that we had missed. The algorithm picked them up, pointed them to us. We went back and looked and said, yes, it is correct. That's a met. But we would have missed them. So we do this. We know we all miss a few mets here and there. But things like this could help us catch it. Very close correlation. I do volumetric follow-ups on all my patients. So tools like this will help me make that much more automated. And we've shown excellent correlation between these two. All disruption happens by design. You have to work hard at it. If you're innovative, that's not enough. You'll also have to fight the political battles. You'll have to fight the technique, staying alive and not getting brushed aside. And you'll have to find the right people to work with you to do it. I think the biggest gift I got from my training at All India Institute was when I was handed off to Dr. Steiner, by Dr. Tunman, Dr. Banerjee. They all told me I was doing this in the June of my senior year. Oh, you're not going to get any fellowships. It's too late. They already have their people. But I was fortunate. I think John Jane had a role to play in that, and Steiner took me as the Lexell Fellow, and the rest is history. Thank you very much.
Thank you, Professor Prasad, for that wonderful oration. I now request Professor M. Srinivas, the Director of AIIMS, and Professor K.K. Burma, the Dean Academics of AIIMS, to present Professor Dheerendra Prasad a memento and a certificate. Now I request Dr. Sweta Kedia of Department of Neurosurgery to propose a vote of thanks.
Thank you, everybody. At the outset, on behalf of Department of Neurosurgery and also on behalf of All India Institute Medical Sciences, Delhi, I would like to extend our thanks to Professor Dheerendra Prasad and the family to have found time to come here and decided to spend few days with us and teach us. It's always been a pleasure to listen to you, sir, and you have always been mentoring us. I also would like to thank Professor Srinivas, Professor K.K. Varma sir to have found time, Professor Girija sir to have come here and help us finish the 34th Sarveshwari Oration successfully. All the senior faculty members, I see Professor Bal, I see Chief of Neurosciences Center, Dr. Sarvesh Gaikwad. All the ex-senior faculty members are also here to grace the occasion, and all the delegates, my faculty colleagues, and my dear residents. Thank you all to make this occasion a great success. Professor P.N. Tandon is also here, so thank you, sir, for being with us always. And now I invite all of you to join us for the breakfast, and we will discuss the remaining cases after the breakfast. Thank you.